Okay, says that I've just started our live. Thank you guys. It's Monday. Gosh, it's going by so quickly, this quarantine. Tonight, I'm really excited to have a fellow colleague from New York City who is going to be talking about facelifts with us. I'm really excited. A lot of my patients have asked for information as to, what facelifts are, what the different kinds of facelifts are, the downtime for them. And, since I'm one of the first ports of entry for plastic surgery, sometimes people aim to ask me all these questions when they come in for their little tweaks, and sometimes for blepharoplasty. Sometimes they need more, sometimes they need just what I can do. So I thought it would be interesting to have him join us to discuss a little bit more in detail. And I see that he is on there. I'm going to see if I can connect to him or if he can connect to me. Let's see. Go live. And yay! Hi, how are you? Are you in the office right now?
I'm at the office just doing admin work, and we're trying to set up for eventual opening. So let's see.
Well, thank you so much for joining me. I feel so weird. For those of you that don't know, you have a twin brother, and I went to Georgetown with him, and so it's just weird to see your face and not know that you're not the same person that I did in college.
I'm the other one.
You're the other one. I won't say which one's the better looking one.
Well, we do know one of us is nothing better at doing facelifts than the other one.
So I wanted to talk to you because, one of the things that a lot of people come in to see me for, obviously, is their non-surgical as well as blepharoplasties and sometimes brow lifts and basically the periorbital area. But obviously, when you start to have some aging in the eyes, it's also the neck and the jawline and kind of everything else. And one of the most common questions I get is, what's the different type of lower facelift or facelift in general, deep plane versus SMAS, and if you can say what they are, why one person would be better for one thing versus another, just to give our listeners, just an understanding.
Sure. I think people overall get, I guess there's so much information out there. I guess it's great for patients to be educated, but I think people really get bogged down in the minutia. And when it comes, I think from a patient standpoint, for me, this is not really important, the technique or how it's done. For me, it's more important on what your surgeon's consistent results are and how many of these procedures they do. But to break down a SMAS versus a deep plane, in my head or in general, the deep plane releases a lot more of the ligaments. So there's three of them, usually in a line from your mandible up to the cheekbone, the zygoma here, and also goes underneath the SMAS layer further into the neck. So once you're able to release the deep plane layer, you're able to get more of a lift, and you're also able to get more of a lift in the mid-face area versus a regular facelift. And there are multiple ways to address that SMAS layer, whether it's just folding it over, whether it's doing a small cut, whether it's doing a little undermining. So I guess those are the two big classifications.
So before, when people use it's true, my voice, someone just wrote that my voice, I might hang up and try again because I think that my voice, for some reason, let me see if I can get this. Does this help? No.
It sounds fine to me.
Sounds fine to you? Okay. So basically, before, facelifts used to be those horrible sort of thing where they would just take the skin and just pull it upwards.
Right.
And then there's the SMAS, which takes part of the skin and the underlying structures, and then there's deep. I think a lot of people worry that with deep, they're getting a lot more trauma because you're going deeper. So, what makes you choose a SMAS facelift, lower facelift versus a deep plane one? Is there a different criteria for those patients?
So for me, depending how advanced you are in the aging process, if I have a patient coming in their late 60s, 70s, I'm going to tend toward the deep plane. But even now, even recently, we're doing patients in their, we're having younger patients coming in, so I'm still able to do a deep plane or a sub-SMAS elevation in those patients too. I guess it all really depends on the comfort of the surgeon. It shouldn't really mean more recovery. I tell my patients either way, it's 7 to 10 days recovery.
That's it.
But that's kind of what But once again, you have to ask your surgeon. Some people take 12 hours to do a facelift. Some people take 2 to 3 hours. So I think all of that is part of your recovery. Also, the number of surgeries that you combine at one time will also determine the length of recovery. So if you're doing laser skin resurfacing and a fat transfer and a blepharoplasty with the facelift, then you're looking at maybe 14 days of recovery.
Well, what I really like about your, you know what, I'm going to see if I can connect. Give me 1 second. I'm just going to see if I can connect. Am I back? I think that's better now. Oh, okay. Sorry, guys. This is all my fault. I'm going to reconnect to him now. Hi. Sorry about
We're
that.
back.
I wanted to see if I like connected to the Wi-Fi, my voice wouldn't echo because so many people said. So one of the things that I really like about your procedure basically is because you show a lot of it on Instagram. You show what you do. You have a lot of live surgeries, which can be gruesome, but also very educational for people going through the process.
Right.
And when you evaluate someone, I always think that there's sort of 2 types of people: the skinny, thin-skinned people, and then the heavy, jolly people. And the thinner skinned people tend to need a little bit of volumization, maybe a little bit more than the heavier jowly types of skin. And when do you decide how much fat to do, when to do fat, and what would be an average amount of fat? I love all the vials of fat and all the lasers.
In general, we do about 20 cc's of fat per patient per time. If I'm treating multiple areas, because now we've expanded to just, as opposed to just treating the cheeks, we're treating the tear troughs, we're treating the temples, we're treating the brows, we're treating the nasolabials, marionettes, and then we're also taking a portion of fat and we're turning that into nanofat, which is supposed to be just stem cell rich, more for skin rejuvenation. And that we're injecting in the hair, and the face, and the décolleté.
Oh, you're doing all of that together.
Right, so we'll do all that together.
Do you do it also to help recreate the jawline, or not really? Do you do that
I can't do jawline fat transfer at the same time as the lift because all the tissues have been opened, so there's no compartment in which we can place the fat in where it will sit. Otherwise, it'll just spread into all my tissue planes. But when we do the lift, when we're elevating this mass into the area of the jawline, we're essentially adding volume here too, because we're bringing this mass that's over here and folding it over this mass that's back here. So we're almost creating 2 layers over the angle of the mandible that way. So we're able to create some volume here, and with the deep plane, when we elevate, we're able to lift some of the midface as well. So we get some elevation there too.
So that's also something that I really like as well, because I'm going to try and move this. I've never had this before, but everyone keeps commenting on it. I'm going to try and move this because I have a little stand here today, and maybe it's my stand, but I'm not sure. But what was it? Well, I forgot what I was in my train of thought, but what I do like, so sometimes when people come in for their lower eyelids, sometimes, not always, a lot of times, if they're younger, you can do a lot of things without having to resort to surgery. But as you get older and you become more jowly and you have mid-face ptosis, I always feel that actually if you do lift this area, I mean, my nasolabial fold disappears, obviously, and sometimes that nasojugal groove, which is that line that goes, sort of like this all the way across, can be improved without having to put lots of fillers in there or other substances to help lift it, because you still won't get rid of all of this stuff no matter how much you're trying to lift your face with injectables.
Correct.
But you do a lot of injectables too, so how do you decide who's going to have the injectable and who's going to have the facelift?
The facelift is primarily patients who are interested in further improvement of the lower face and upper neck area, which are very different than majority of my injectable patients, which they range in ages from 20s and up. The injectables are primarily recreating the mid-face volume loss, and then we have those patients that want jawline accentuation or chin accentuation. But those are patients that can do very well with injectables, but there's a certain point where when you have so much skin laxity that you can't inflate that balloon so much, otherwise the entire face gets big.
Is there a ballpark number? Is it like an inch, 2 inches, you know? What is it that you know is your cutoff for that?
For skin, for the laxity?
Yes.
You know, it's more just of a feeling. When once I start putting even one syringe or one, I usually don't go more than one per side, but if we do one syringe of, let's say, Voluma per cheek here, and we're not seeing any improvement in the jowl or the lower face, then those patients are most likely just going to be candidates for something more substantial. But there are other things you can do for skin tightening besides facelift, right? So there's a whole host of these non-invasive procedures that my patients also have done, whether it's smart lipo or precision TX, or whether it's all therapy or thread lifts. Those are all things that can be combined with fillers.
Do you like using threads?
We have started that about a year now. The results are okay. I think there is a subgroup of patients that are looking for that are happy with the longevity of the results and happy with the minimal downtime. And
do you find that makes it more difficult to operate later? Is there more scarring in those patients?
You know, it's a great question. I have worked, I've done we do plenty of, with the kind of practice that we have, we do a lot of secondary facelifts, tertiary facelifts. So those are all patients that have had significant scar tissue from their first or second facelifts. And it's relatively straightforward once you're in the right planes. So whether they've had all therapy or whether they've had a thread lift, or even whether they have significant acne scarring from when they were younger, those are all patients that we're just extra careful with how we're elevating the skin layer and the deep plane layer. The good thing about the deep plane layer is that all these treatments like thread lifts and all therapies, they haven't gone that deep. So once I'm in the deep plane, I'm in a clear area of operating again.
And do you combine those treatments? So a lot of people, plastic surgeons, I do all therapy, I do Morpheus8. I think both of those are good for early onset jowling that are not yet ready for having surgery done. Obviously, I always tell patients they're never going to be as good as a facelift themselves, but it's a nice way when you're younger, in your 30s and early 40s, sometimes even longer if people don't want to go through the downtime of having surgery, that's a good option to have. But how long afterwards can you have it? So you combine I see you do a lot of CO2 laser at the same time. When can someone, after having a facelift, then have an all therapy treatment, or then continue on with radio frequency like Morpheus8 or whatever it might be that they're wanting?
You know, usually after a few years, when they start noticing some of the sagging and jowling again. But if they keep up with we put them on a regimen of whether it's good skincare, laser skin treatments, fillers and injectables. And then, you know, after a few years, if they want some tightening or lifting, they can get a little all therapy or the Morpheus or those energy-based devices.
So you wouldn't do like an all therapy at 6 months after surgery to help tighten that skin while it's still healing?
No, but once again, we have, because there's always that subset of patients who just need a little bit of extra lifting or tightening, especially if they have a history of significant sun exposure in the past. So those patients, even after we lift and tighten them, there's always a little bit of laxity. And that's more of a function of their inelasticity and their collagen rather than us not having lifted enough.
And you know, you do CO2 a lot. Is that really more for texture of the skin that you're doing it, I'm assuming, other than?
Yeah, because I have a lot of my patients, my baby boomer patients in their 50s and 60s and 70s, they've all been tanning a lot when they're younger. So a lot of them have the surface rhytids, little fine lines, wrinkles, sunspots. So I really find it really helps airbrush their skin nicely. And if they're going to take the time to heal, why not do it all at once?
So do you find that the laser takes longer to heal or the facelift?
Once again, really by about 14 days, most people, we say, are restaurant ready. Some people take a little longer, some people take a little quicker, but most of them with some makeup, by 14 days, they're okay.
And where's the scar for all of these surgeries?
I will go back to the laser for 1 second. The laser, I can adjust the settings, so I don't have to go full blast, fully ablative on every patient.
Okay.
So
Do you do mainly fractional ablative laser, or do you do fully ablative?
They're all fractional.
They're all fractional.
Which is why also the healing's much better. Incisions for the facelift are a little bit up in the hair tuft here, in the superior auricle crease behind the cartilage, the tragus here, around the earlobe back here, and then back here. I actually just did a little post with an Instagram video of, I think 2 or 3 days ago on my IGTV. We posted about a mini lift versus facelift, and we actually showed all the incisions exactly
All
how
the
they're
incision
placed.
scars?
Yeah. And for the neck lift, it's a tiny one right under the chin here.
So I see a lot of these, and I always think that when they get older, I can sort of see the platysmal bands forming again, and it almost stops right there. So when you do this submental area, do you also then cut the bands so that they don't get that pulling later on?
Right. But the bands naturally attach right here anyway, so that's where they're going to start separating anyway. But yes, in my patients, most of the time, very rarely am I doing a facelift by itself. 95% of the time I'm doing it with a neck lift. Even if they're in the early stages of the neck banding, I always tell them, I give them the option. I'm like, if you do it now, then in 5-10 years, your face will look great and your neck won't if you did not do it right now. Otherwise, if you feel like it's not heavy enough, then we can hold off. But I have many patients in my practice who had a facelift early on, and now their necks have fallen. So
and when you add the neck, does that incision then go into the hairline, which is higher?
Either way, even when I'm doing a lower facelift, correct. I go a little further back in the hairline. The length of this posterior incision depends really on how much laxity they have in their neck, because that's where we remove all of the neck skin.
I love all this stuff. I love the idea of stretching it out like a tissue and just cutting it off and like literally tweaking, cutting, snip and tuck, basically.
Right.
The other thing do a lot of people at this time, so, actually with bony resorption and chins change, dental, dentition changes, there's so many different changes, bony changes that happen in the body. Do you often feel that you need to supplement that with either like a little bit of a chin, implants along that area, or you think that usually by just redraping and pulling back with the muscle and the other layers that you get a good, long-term result?
So my favorite combination is doing the facelift with a fat transfer. So when I'm doing the fat transfer, we're doing a lot of chin augmentation now with the fat transfers. Results are really phenomenal because there are areas of high resorption when you put the fat in. So some areas, when you place the fat lasts very long, and other areas it doesn't last very long. So the cheek is one area that does really well. The chin is one area that does very well with the fat. So we are doing a lot of building out the soft tissue down here when we are doing the facelifts, when they're doing the fat transfers with it.
Do you do the fat transfers in the forehead and the temples as well at the same time?
Yeah, we'll do the brow, the temples. We're even I'm filling in a lot of the upper eyelid hollows, the sulcus over there too. We're getting very nice results with that, especially with the nano fat or the micro fat that we do.
And do you have a lot of resorption in that area?
The upper lids, no. The upper lids tend to take it very well. It either takes it 100% or it doesn't take it at all. But in general, our patients do very well because it's one of these areas also that don't move very much. So unlike the lips or the perioral, the lower face area, where the fat tends to resorb a little more.
And do you do it in the lips, fat transfer into the lips at the same time?
If I'm doing it to the lips, we haven't had a big request for that.
I always feel that that's also a giveaway as you get older. If you're somebody who has worn heavy earrings in the past, the earlobe just elongates. And I think sometimes the face looks really good, and then you see these earlobes that are extra long.
Right.
What happens with the men who have hair, like for yourself, if you were to do a lift?
We adjust the incisions, but for most of my male patients, by the time we're a candidate for having the procedure, most of us have a deep crease right here already, so we can use that same crease in front of the hairline. If I do decide to go retrotragal behind the tragus over here, patients can get some laser hair removal and stuff. Because I guess we should explain to your audience what you're referring to is that the moving of the beard line further back. So things that I counsel my male patient are that your hairline will move back, and that you're going to shave behind the ear now too, because your skin in your neck is now behind the ear, but for those patients, laser hair removal can be done to readjust the hairline.
Yeah, I think it would be weird all of a sudden sprouting hair in areas that you didn't have. Men already get ear hair, so then you're going to have ear hair just in the tragus area.
Right.
But that's also very easy to do, laser hair removal in that area, so it's not really
Right.
sort of
So that's not hasn't really been an issue.
And a regular mini lift. So I always, I feel like a mini lift is the same thing as a face. I mean, I find that that's sort of like a trade on words. A mini lift to me means the same thing as a facelift. Is there a difference between the two?
So, yes, in my eyes, the mini lift, I'll use a shorter incision. So as opposed to extending from the hair tuft all the way then back here in the hairline, I'll limit it to just around the ear. So just in the sulcus up here, behind the tragus, around the earlobe and back here. So like a little J incision. So it's a much shorter incision, and there's less undermining of the skin and SMAS layer that we treat.
Mm. And you can do that. The mini one is, you could be a SMAS or a deep plane, either way. You can do that either way.
Right, but for the mini, I would not go extended deep plane, because then you're going to have all this soft tissue to be able to lift, but then you can't you can't remove all that skin because the incisions are small. The reason for the length of the incision is that you're able to remove all the extra skin.
Yeah.
But once you have a shorter incision, there's no point doing all that extra work, because even if I'm able to lift, then where do I where do I tailor the extra skin? You know?
Actually, a lot of people, there's somebody in California who does a lot of ponytail lifts, and I hear a lot about this ponytail lift, and it appears to me, and I'm not sure if this is correct, but it's just an endoscopic brow lift. But then I've seen some patients that have extensive scarring after having had a ponytail facelift that goes really into their hairline right here, almost. I mean, it's really quite excessive, which I don't like, because I feel like the scarring in this area is not very good at all. If you put tension on this at all, you get, like, yes, I can get that appearance of my brow, which I don't like personally for myself, but I feel that skin is very, already quite taut, and so it stretches really quite significantly, and it's a dead giveaway. I mean, I wear my hair down so I could probably hide it, but I also like to wear my hair in a ponytail, so I mean, I would never want to have that sort of scar. Do you do a lot of endoscopic brow lifts or brow lifts in general?
I don't do very many brow lifts. Maybe 10% of the time we'll do a brow lift. They're not endoscopic. I'll do a lateral temporal brow lift, similar to how Dr. Guy Massery teaches it.
Yeah.
It's pretty much an incision over here over the temporalis muscle, and then we elevate all the soft tissue over the brow, over the lateral canthus, and then back here. Plus, we do a little bit of undermining on the back, and we elevate subgaleal across the forehead too. And then I lift, and I use an endotine just to hold the soft tissues up, and then we close.
So an endotine kind of feels like two little screws in your scalp. So you can feel that a little bit for a little while. Not that I've had one, but I've obviously done a bunch of these myself. So like I always find that's really, if someone likes to give themselves like a head massage, that's like a weird sensation to have something underneath your skin. And are you doing forehead shortenings? Because I feel like that's become a thing all of a sudden. I mean,
we're doing a lot of hair transplants, but we're not doing forehead shortening.
What do you think that's going to look like in like 10 years time? Because I don't know if there's just a few doctors doing it, but for some reason, I'm not sure even why I'm SEO'd so that it's coming to me. But like I see this all the time, people, lifting their foreheads and elevating their brows that way, and also, decreasing their hair, shortening their hairline. So I feel that is very highly invasive, and potential for scarring there again is like so dramatic.
Yeah, but that's become very, very popular now, especially for the facial feminization surgeries. That's where I would say the highest volume of these forehead lowering procedures are being done.
But can't you accomplish the same thing with a hair transplant?
Yes, I think so too. I think you can, but I think I think there's two things. I think you can with a hair transplant, but it depends how much hair you have to donate to create the new hairline.
Where are you using? Where is your donor right now for your transplant? Like, what is
We're doing the FUE technique, so we're getting it usually from the back of the head or the sides, and then we're placing it wherever in the recipient sites wherever we need to.
And how well are they staying now with the recipients? Are they,
Pretty good, yeah. No, we're getting great results. I mean, the way the hair transplants work is you have a experienced team that works with you because it's very tedious work.
Long.
It takes all day, so we'll start at like 8 o'clock, 7:30, 8. We'll be done by like 4:35 p.m.
Just one session?
Well, we tell most patients they're going to need 2 sessions because you can only do about 2,000, 2,500 grafts a session. So
this little area here that people do, is that approximately 2,500 hairs, or is that something more?
Yeah, that's usually about 1,500 to 2,000 hairs back there. So that's probably its own session. And usually, if you're going to build out the frontal hairline, you need at least 1,700 to 2,000 grafts as well.
Do you have a lot of women doing this too?
Right now, it's mostly men. This is the other side of me for my practice. It's like 80-20 men. For the facelifts, it's 80-20 women.
What's the most common procedure you do?
Facelifts.
Facelifts?
Yeah, aside from all the injectables and lasers, it's facelifts.
And what about noses, since you're an ENT surgeon?
I don't do any of that. That was another lifetime ago. I have colleagues that work with me, so they do a lot of my rhinoplasty surgeries. I think rhinoplasty is its own thing. I think you have to be doing the volumes to get the consistency and results for rhinoplasty. So I don't want to be, especially in a place like New York. You're lucky. It's the same like where you are. You're lucky that you can kind of super specialize in a couple
I think that's so important. That's one of the things that I tell a lot of people. Like, I'd rather be really good at, my little arsenal of treatments and then send people to others. Obviously, if someone needs a facelift and they need a Blvd and, all of this stuff, I'd rather have them do it with one person who can kind of combine everything together.
Right.
But I always try to minimize the amount of sleeping time they might need. You also do a lot of your procedures awake. Your patients are awake. So can you go through that? Because I think that's also one of the things that really scares people when they want to have a facelift, is they think, oh my God, it's going to take like 10 hours. I'm going to be under for 10 hours. And, I'm going to die during surgery. And that is really one of the things that people are the most scared about. And I try to tell them, that's one. And then second is for downtime, how much time they can take away from their families, from work, and, normal life again. So how come you do so many of yours while your patients are awake? And you do them in your office?
Yeah, so we have certified operating rooms, facilities over here. So in America, we have the Quad A certifications, which is outpatient surgery centers. We meet certain criteria to be able to do it under IV sedation or general anesthesia or just local anesthesia. I do it under local because I can. So I was alluding to this earlier. So, a doctor who has a lot of experience with these surgeries, the facelift should not take more than 2 hours. Okay, so if we are doing, let me rephrase that. Not that it should not take more than 2 hours. If you're going to do it under local, you can't take more than 2 hours for your facelift. Okay, because once again, if you're going to take 6 to 8 hours to do a facelift, then the patient's definitely not going to be comfortable. We do all of our procedures within 4 hours. So whether we're adding a blepharoplasty, fat transfer, brow lift, laser, face and neck lift, we're able to do it all within 4 hours, because that's kind of the longest I want to keep the patient on the table. If we're just doing facelifts, it's an hour and a half, maybe 2 hours, even with face and neck lift.
What do you do first? You do the body part first, and then the face, or you do the other way around?
Say that body part first.
Like you do the lipo, the fat. You do carbon fat first.
I do it during. It's all kind of during. So as when I'm done with the neck lift, I'll anesthetize the abdomen. I'll start the facelift on one side. Then when the abdomen is numb, I'll harvest the fat. I'll do the facelift on the other side. Then by that time, my team is processing the fat. Then I'll go back to the neck and close up the neck, and then the fat transfer is ready. So we kind of do everything kind of at once. We have like a little system that we do. So
do you put fat in the neck as well?
No.
So what do you do for the aging neck? I feel that's one of the areas that once you've already had surgery, that's almost returns a little bit sooner than the jowling does.
Yes, so the neck is the most unreliable out of the face and neck lifts that we do. But once again, when we're doing these deep plane or deep elevations, when I'm elevating the SMAS, the platysma is also attached to the SMAS. So when we elevate the SMAS, we're able to get some contouring in the neck as well. So that combined with what's called the platysmoplasty, the neck lift, where we tighten the front of the neck bands together, then I think you get the best results. There are many ways and techniques to get those results, but your surgeon should be able to tell you their preferred technique.
Good to know. Good. And you also do a lot of lip lifts at the same time as well, I saw.
Yeah, so we've been doing a lot of those recently too. I think they've become all the rage. I think we're having younger and younger people coming in for those procedures too. The lip lifts are great procedures. There's a subset of patients that we do have to manage the scarring afterwards. So even for my facelift patients, we put them on a protocol of erbium and IPL.
How soon after surgery?
We'll start that almost like 2 to 3 weeks after surgery. And we haven't come back.
This scar here, I kind of think sometimes it looks like when you've had an open rhinoplasty and you can see the scar that goes, but it can be more significant and it can cause a little bit of dipping sometimes, I guess if it's not done in the right hands. So I think that's a great procedure for people who've had, so lip lift is great when you have like a super elongated upper lip, the white part of your lip, which can happen with time, dentition changes, and also I think with repetitive botulinum toxin injections in there too, you can almost loosen all of that skin area up. But I always wonder, because sometimes, obviously the good scars you don't see, but the bad ones are the ones that stick out to you, or the ones that come to see me afterwards. Sometimes I have to fill them and do lasers, and sometimes even just recreate the scar. What do you like for your scar management? So, that's also the biggest thing too. I people don't want to have that scar, noticeable.
Right. So most people heal very well because we've placed the scars in these subunits, the transitions from the cheek to the ear subunit area. So these are like camouflage areas, but we do offer our patients. Everyone gets this option. We put them on a protocol of erbium skin resurfacing, erbium laser skin resurfacing, as well as IPLs. Because even my fairer skin patients, my Fitzpatrick's 1 and 2, my lighter skin patients, when they're healing afterwards, they get a little redness or vascularity on the skin of the face and the neck. So for those patients too, we're doing these IPLs. We're getting very nice results. Allows them to camouflage the areas easier, and I'm feeling the scar management is much more.
Do you do those lasers on the neck simultaneously too? I see them often on the face, but you take them all the way down to the neck?
We'll do the CO2 in the neck. We'll also do it in the décolleté. So we kind of put it everywhere.
You do. It's like you come out, and then you say 2 weeks basically. But in order for them to go back to normal, someone's going on television, they're a reporter, a news reporter. How long do you tell them that they need to stay away from the camera?
We'll tell them 3 weeks then. It all depends. If you're doing laser with fat transfer, that really causes a lot of swelling, especially when we're working in the periocular area. So for me, that's the bane of my existence. I don't know how you deal with it, but you can get a lot of edema in this area, in the under eye tear trough area, where I'm placing the fat transfer and I'm doing periocular laser, or I'm doing a lower Blvd at the same time. So that, and I also discourage my patients from using ice packs over the fat transferred area. So that really also doesn't help the edema and the swelling afterwards. So I have a subset of patients that do, I would say about 10% of patients take a little longer to heal, but most patients about 2 to 3 weeks, 80% of them are say restaurant ready, and they can cover up the areas with some makeup.
And what do you give them post-op other than antibiotics and, pain?
We give them nausea medication just in case. That's pretty much it. We, if they're getting a laser, we put them on an antiviral medication too. Antiviral, antiviral medication. We'll also give them, that's it. I will put them on steroids only if after 3 weeks they still have that swelling.
Makes sense. Someone here has asked for the lip scar. From time to time becomes hyperpigmented. Do you do erbium or IPL on these patients?
Yes.
Both?
Yes. Both. We'll do the IPL first, then we'll hit them with the erbium.
And do you ever have to redo that scar for the lip lift?
I've had one patient I had to redo it on. It was one of my first patients. So yes. I can't think of many that I've had, any other ones that I've had to read, but we've done quite a few. But it's actually one of my first patients that we had to. She unfortunately tended to keloid and developed some hypertrophic scarring over there. In retrospect, I don't know what I would have done different, but we are being more aggressive with steroid injections and these IPL erbium laser skin resurfacing.
For your patients that come out of town, how soon afterwards do you let them fly?
We say 2 weeks.
2 weeks in New York.
Yeah, so we had a patient from Dubai come in. We made him wait 2 weeks before he left. Trying to think recently.
When you take the stitches out, when 10 days or 2?
So with the way I do my suturing too, I do mostly a subcuticular closure, so there's very little sutures to take out, and it's a dissolvable monocrol suture. So the only one that needs to be taken out is the one in the hair tuft up here, and that one gets removed at a week. Then usually there are no other sutures to remove.
So that's pretty easy then.
So it's much easier. It's been easier on my staff, and it's easier on patients too. I think it's easier for the patients too. Less wound care to worry about.
Also, probably a little bit more comfortable. I think every time you have a stitch somewhere and something touches it, it's going to be more painful.
Exactly.
Someone's asked, do you routinely do Botox injections at the time of the lip lift to reduce the tension in that area, or?
No. I think the amount of Botox you would need would be counterproductive, because then you're going to have trouble speaking or drinking. Or, yeah.
And do you remove people's fillers before they come in for having facelifts?
No.
No,
never had to do that. They usually bring in pictures of themselves from many years ago, or even from recently, so I can gauge how much they need. The filler is going to go, the fat transfer, the full results you see at about 6 months anyway, so we have time for everything to settle.
Because and have you ever opened up and seen a depot of filler somewhere, along the mandible or the jawline?
No, I've seen some weird white materials sometimes. I'm not sure what it is. Patients say they added that. No, it's not. It's some very weird material. They said they may have had something done years and years ago in some other country, and then I go in there and I look and I see something, but that's the only thing I see that's weird.
And what about people who've had silicone? Because there's, that subgroup of patients from ages ago that had, especially around the lip area, that kind of looks like it migrates, within the lines, the lip lines, and it distorts the area, in my opinion. I don't think it's a really great product. But what about patients like that? How do you rectify that? I see quite a lot of patients who have silicone in their white lip.
We do a lot of silicone lip reductions or contouring after old silicone injections, and that's just more to give patients a semblance of looking a normal lip, because otherwise their lip look very bubbly or asymmetric or
where are those scars?
Unnatural. Usually just in the lower part, on the border between the wet and the dry lip. So usually on the inside of the mouth, and we will excise a wedge of the lip. But it's a wedge that you contour depending on the bulbous nature of the.
So you remove some of the lip tissue at the same time.
Yes, I can't just remove the silicone because it's all incorporated into the tissue.
That's a good way to have like a weak diet. Can't eat or drink very well probably for that time period.
There you go. We just sew the mouth shut.
Yeah, exactly. And what do you tell patients prior to having their procedure? Like, what are the things that they can do to, improve their chances of having the best results?
So we avoid alcohol. We avoid any blood thinners like aspirin or Motrin or Advil. I do suggest some supplements, but once again, these are not a deal breaker. Some patients can take them, some patients don't. It's vitamin C, bromelain, and arnica. Bromelain apparently helps with the swelling. Arnica helps with the bruising, and vitamin C helps with healing. We ask them not to smoke, maintain a healthy diet, avoid the sun. Those are all things that we suggest beforehand.
And exercise how many weeks after surgery?
2 weeks after surgery.
2 weeks?
Yeah.
They can go to SoulCycle?
Pretty much.
Wow.
And once again, it's a conversation I have with the patient too. Some of them are like, "Oh, I still feel a little tight. I know when I'm doing yoga, I'm like, fine, then wait another week. But you have to listen to yourself.
And then what about numbness in the area? How long will that stay for most patients?
So that can take months and months to come back. So we tell a patient it can take up to 6 months to a year for the full sensation to return, especially like the earlobe area or the side of the ear. For male patients, it bothers us more because we have to shave. So when we shave, we have to be careful because if we cut ourselves, we won't feel it. For women, we tell them to be careful when they put their earrings in because we don't want you pulling your earlobes.
And you don't do the earlobe reduction at the same time, or you do?
I like to. That tends to mess up the healing around the ear. I tend to see a lot of attached earlobes afterwards. So it's such a delicate area because all the work is done around the ear, and then you have an incision right around the ear as well. So in general, I tell my patients I don't like to do any kind of earlobe reductions at the same time as the facelift. I'd rather wait 6 months, 9 months, and then we can address the ear. Because things have changed. Maybe they're like, oh, I like my earlobes now. You know, because everything kind of changes.
Everything changes. So what's the thing that you think you myth bust the most when someone comes into your office about having surgery?
I think the myth bust the most is about what you had mentioned about having to be put out, being put to sleep completely for these procedures, that it takes, 10 hours to do a facelift, that you can't go home, you have to have a nurse, you have to stay overnight in the hospital. I think we have a lot of, that's probably one of the biggest myth busters, that with the technology and the techniques and experience that we have nowadays, these are outpatient surgeries. If you just want a facelift, it can take less than 2 hours. And there is wound care to do. There is a recovery associated with it. But I don't think it is like how it used to be in the past.
And how's the pain afterwards?
Patients are in pain for about 24, 48 hours where they need to take the pain medication. I do routinely use Exparel, which is that long-acting bupivacaine. I put that in all my facelift patients. I did a study where it reduced my post-operative narcotic usage by 50%.
Wow.
And we also now put some Kenalog into the surgical site as well, which is a steroid, an anti-inflammatory. So I haven't done we just did a follow-up study, but with everything going on, we haven't been able to tell you the results. But the post-op narcotic usage is a little less as well at that time.
Do you ever use tranexamic acid?
Yes, we use it every day. So we've been doing that too. So in my my protocol for the tumescent, for the dilute local anesthesia that we use, so if you're going to do these cases under local anesthesia too, you have to be able to do them with a very dilute solution because there's only so much local anesthesia that you can put in your body, in the patient's body at a time. So we use a very dilute solution, and the patients tolerate very well. But I put TXA in there as well, and the TXA is thought to minimize the bruising and swelling afterwards as well. Well, the bruising and bleeding afterwards.
Do you give it to them orally to take when they go home?
No, I just combine it in the solution that I use to inject the patients with the local anesthesia.
Good to know. I use that too. I use it in my solution for my blephs and some of my other surgeries. And sometimes
are you finding a big improvement?
What?
Are you seeing a big improvement?
Yes. I mean, I have, you also, I mean, I like the fact that you show so many of your results every time that you're operating. And your post-op patients and the truthness that's behind it, I do think that it decreases bruising in those patients. And I think when they do have bruises, it heals much faster. So I'm a big fan of tranexamic acid. Of course, I use some steroid as well, so.
Good. So you give orally? You give them intravenously for the steroid?
No, I give it all. Yes, well, if they're under sedation, then I give it intravenously. But I also have it in my local anesthetic too. So everybody I operate on has local as well. Minimum has local, and then they might have something going IV. Or some people here just like to have everything under light general. So quick in and out. But all those people get it, and a little shot of antibiotics too, just to have some coverage. But touch wood, all of these things have very low risk of having those types of complications. And what is the one thing that you always, as a surgeon, are the most scared about? You know, you've done so many of these; it's almost like second nature. Of course, you know, complications can happen in the best of hands and to anybody at any time. But what is the thing that you always tell patients? I really want to know about this. If this happens to you during the time, don't think you're being needy by calling me. But what is it that you tell them?
I think the good thing about our practice is that we have a pretty good relationship with our patients. They all get my cell phone right after, so they know to call me for anything.
But do they?
They do, and they will. But we're also checking in on them regularly. Like I'll call them. We call them almost every day after surgery. But anything acute, severe pain, severe swelling, those are all things that can mean you're having acute bleeding going on. So those are questions. Those are things that I tell patients. For me, it's not really a big concern because if they do have bleeding, they come in, we stop the bleeding, and then they go home. All it does is that it delays their healing. But for me, for patients, they have to go through the consent forms, and they just have to understand all the potential risks of the procedures. You know, we alluded to some of the scarring that can happen afterwards. Thankfully, it's all very minimal. There's bleeding that can happen. There's sensory loss that can happen. Those are all potential risks of all these procedures that we do. Whether it's nerve damage where you can't move your face, thankfully never had that happen. But those are all potential risks, that can potentially occur.
So what do you think is going to happen now with COVID? Like, when do you think you're going to start being able to operate and do these facelifts?
So unfortunately, we are classified as non-essential, and I think cosmetic surgery is going to come online last because it's the most elective out of elective surgeries. We're going to follow the protocols. That's what we're here trying to set up. Workflows here. I think it's a social distancing, cleaning. We're going to be offering testing now too for the antibody and the PCR testing. So I'm in with my staff today trying to set that up especially for our surgical patients, because I don't want them to. I think that's going to be a requirement. Here in the U.S. for any patients undergoing surgery, they're going to have to be tested.
I think that's a great idea. I'd want to be tested if I were undergoing surgery myself.
Right. So I got my antibody testing last week at the hospital that I'm affiliated with. They offered it, so I did it. But I know I was negative last week. But what am I now? Right. So it's such a.
I know that's the problem. It's not like you do it once and then you know for sure. Unless you've already had it and then I've already had it, so I feel like I almost feel a little bit more relieved that I have. So I can't give it to anybody else. No one can give it to me, and
Right. I almost wish at this point that I've had it, but I haven't.
Walk around New York City. Go around the block.
I'm not gonna do that. I gotta worry about my kids.
Well, I saw that Central Park had so many people in it the other day. It was crazy. Your quarantine is it's just as strict as it is here in London. People are out and about.
The weather's become so nice the last couple of days, but I think people are wearing masks. People are social distancing still.
Yeah. And then, so are there any guidelines in the United States as to what they want to do for for all the doctors? Because everybody, doesn't matter if you're a plastic surgeon or a GP, most doctors have patients waiting in their waiting room. So,
yeah. So we have. I'm looking over here. We just printed a whole bunch of guidelines there's a bunch of plastic surgery societies, but the CDC has their guidelines also on the up on their website. And for us, it's going to be patients we're going to institute a policy where patients wait outside and don't come in until we call them, and they'll go straight to their rooms. We're not going to have any we're going to do the screening, the questionnaire that we ask them, with any sick contacts, any fevers. We're going to check their temperatures and check their.
And the testing, is there adequate testing there right now to have all of these tests done?
It's coming, but the testing we're offering is I'm purchasing the antibody testing. So I'm going to have a bunch of kits here that we can offer to our patients, like we offer pregnancy tests, and then we're also going to offer the PCR testing, but that's going to be through a lab. So we'll do the swab here, and we'll send it, and that takes about 24, 48 hours to get the results back.
So you do that for all your pre-op patients, basically 48 hours
Yeah, but
before
they have to be
surgery,
done
so that they know
close enough.
definitively.
Right, but
And I
they have
guess
to
they
be
have
done.
to socially isolate for those 48 hours prior to surgery.
Exactly. So we have to have everyone. So it's going to be it's a whole new world. I don't know. I don't know how or what or I don't know how it's going to happen. I don't know. There's so many unknowns. I think at this point it's just a day at a time and just try to keep the lights on.
Yeah, I know it's an interesting time for sure. And
Yeah.
did you just move into your new office, or are you?
No, it's under construction, and well, it's that's non-essential at this point too. So there's no construction happening. So unfortunately, we're delayed. We have at least 3 months more of that project to go.
So after summer, hopefully after summer, this will be, a little memory in the past, going to forgetting about it, altogether. But thank you so much. I love talking to fellow colleagues, and I think it's really important. I'm going to keep it up on my Instagram Live, and then I'll try and save it, and I'll send it to you. But I think it's really nice to be able to share this information because lots of people like to know what a facelift entails, and I think that the word facelift, the first thing you think of is like this pulled back, tunnel, windswept look that doesn't look natural. And I think, as you said, looking at results, some doctors don't like to put their results up because I don't know why. I think that's the only way you can tell if you like the hand of the doctor.
Yeah, I think for me, I show so much. People are like, why do you show so much? Because I'm like, if I wanted to do this, I want to know everything.
Yeah, of course.
And there's a lot of misinformation or just old information out there. And I think I'm doing a service by showing it on, and then I show the recovery, and I think being transparent, I think is important.
Yeah, I think I'm just holding it here to see, but I agree. I think it's really nice, and I like that you follow your stories through, so like your patients through. So anybody who wants to, I will also put a link up to your Instagram page so that they can check out your own work.
Thank you so much.
I keep saying I'm going to bring my mom. I was actually meant to be in New York City last month, but, didn't happen.
Next time.
So maybe on the next trip.
Next time for sure.
All right. Thank you so much.
Lovely chatting with you. Take care.
To see you soon. Good luck with everything that's going on there.
Thank you. You too. Bye-bye.
Thanks. Bye.